you. So let us go through biometry and IOL power calculation. Please run through the. Can you run through it? As we know, IOL power calculation in children is different from that in adults, in that the axial length, corneal flattening, lenticular flattening, all these happen very fast during the initial 6 months, and during emmetropization, that is about 6 to 18 months, they have a fast corneal flattening from about 52 to 44, and then axial length from 17 to 24, and lenticular flattening also occurs. Yes, you can just run it. And next. So, that's what I think you can just run. I don't have to talk. Please. So the pattern of axial length growth during the first 6 months, second phase up to 2 years, and beyond up to 3 years. That is why we usually in bilateral cataract, we wait up to about 18 months to 2 years to implant an IOL, and do it later as a secondary procedure. Next. So the myopic shift, axial length and keratometry measurement, IOL power calculation are challenges. Next. How we would measure? Of course, under anesthesia would be preferable, because children, immersion technique is good, or optical is not always possible in children, and coupling fluid is used in immersion technique. Yes. Next. So keratometry, now handheld keratometers are available. That is, under anesthesia you can calculate the keratometry and calculate IOL power. Next. Optical biometry in the older children, it is not it is possible, but in the newborn baby it is not possible. So these are the different. This is all the baby, with the baby sitting, not lying down. Next. Next. So how optical is always better if it is possible in the older children, but immersion technique has to be done in the young. Yes. So so what is the target? Residual hyperopia from. Next. This is what we aim. 17 millimeter IOL power, what is this is approximate IOL power in a normal eye. So this is the protocol. When to implant an IOL, in the bag or in the sulcus. These are SRK, SRK2 are the commonly used is SRK2 and SRKT. Some comparison of accuracy of IOL power calculation. Lot of papers are there. They go for IOL power formula. For SRKT has been found to be universally accepted for any microphthalmic and large eyes also. But Hoffman Q is better in small eyes, but we do SRK2. Yes. I think most of the Barrett's formula has been also studied well, and used in the very small eyes when the axial length is small. I think that is when all these have to be taken into consideration. But during otherwise SRK2 or even Barrett's as an adult can be used. The predicted errors below 2 years, SRK2 has been found to be the lowest. So that is why we take SRK2. Yes. Barrett's 98% error, predicted error within 0.75. In spite of all these IOL power calculations, a lot of predictive errors occur. we undercorrect for about 6 diopters and we see next day post-operatively it's just about 2 diopters or 3 diopters. It's not always as predicted that it comes. Actually, I think it takes still longer time for us to come to a predicted error 0. It is, I don't know whether it is possible at all. What is your experience? I would like to know from the panel, Dr. Satish. Do you exactly get what you predicted? I mean, 1 year old, you predicted 20% undercorrection. Do you get them?
Yeah, no, not always. No. But I don't fuss too much because anyway these are growing eyes. We don't know how they would grow. So there anyway there's unpredictability. So unless it's a gross error.
Yeah. I had a 4-month-old, not 4, 3-month-old, less than 3-month-old baby, and the eye was little small, but of course it is more than 10.5, and axial length also was 17.5. And then, considering the difficulties of contact lens wear and patching, I decided that I will implant an IOL. The power was 42, and then I implanted 30 diopters. You know, after 6 weeks, the immediate post-operatively, the post-op hypermetropia was 15. And then the child came for the first 1 month, 6 diopters. That is the growth. The child grows so fast that you cannot predict how hypermetropia would reduce. But luckily, he's having straight unilateral cataract, straight eyes, fixing very well. He's not using, now he is almost +1, +1.5 only. He's 1.5 to 2 years now, doing very well, no strabismus. It's very surprising, but I'm happy that I implanted the IOL because sometimes in the initial stages, I was really scared to see this +15. Yes. It varies from child to child. Usually by about 8 years, we can say if he is not myopic. If there was a myopia already, or if you see a posterior polar thinning, looks like a myopic child, that sometimes from the fundus examination you get an idea that it is going to be myopic. Then I've seen, like any other myopia, it can progress up to 18 years. Like myopia. So we have to follow them up for myopia. Very unpredictable, but in myopia more so. So that's why we undercorrect more in myopia. Especially in unilateral, you undercorrect more also. Then management also is difficult during the initial stages when there is a large anisometropia. So they have to be followed up because we can't discuss all these things. Unilateral myopia, unilateral cases, myopia, specifically you have to say undercorrection should be more because you expect the eye to go myopic again for a very long time.
Do you have any difference in the posterior capsulotomy in high myopes, madam?
High myopes, eyes are more collapsible because the scleral rigidity is less, and so sometimes, actually, when you do PPC, you don't need to inflate more and make the bag very deep because catching hold of the posterior capsule becomes more difficult. And then in myopes, because of the collapse of the globe, it may keep on changing. The focusing may have to be
because
changed.
I burned my fingers once. It was like a high myope, and it was a sticklers actually. And the vitreous was very thin. I did a proper capsulotomy and everything went on well in the bag IOL. And after 3 months, some severe trauma, the IOL dropped. So it was like a fluid vitreous. I could realize it. I should have put it in the sulcus actually. A 3-piece
Stickler is not very uncommon, and you don't.
Actually, the father also had that, but that didn't cross my mind. The brother also I did. Then I put it in the sulcus, 3-piece.
Usually Marfan syndrome, it is not the cataract which is troubling you. It is when the equator bisects the pupil. That is when they don't improve beyond 636 or something like that. Then till then, if we can be improved with either the myopic correction, if the lens has moved still further, and then phakic correction can be done. Either myopic correction for the phakic part or hypermetropic correction for the aphakic part can be up to 618 vision you can wait. Usually they go on till 8 years. That is when we need to operate. But it is not a hard and fast rule. But that is the age between 8 to 10, later part of the first decade. I use mostly now for the past probably 2008 to 14 years I am using iris claw. Scleral used to be long time back, but not now.
Posterior.
Posterior retrofixation.
I have given up iris claw lenses because I got a few atrophy of the iris. So I was feeling bad, like one side it got detached. Then I reattached, but still I feel bad. Now I do only SFIO.
Yeah, I think
Blue
these
dye.
patients have a predisposition for myopia also. Because the scleral rigidity is less. Marfans, many of them have a myopia. They have flat cornea, they have high myopia. So the refractive status may not be big different, but because of the flat cornea also. But they have changes in the fundus like myopia. So you have to be very careful. I had a child who had a disenclavation of one iris claw, and then it was re-enclavated. He came after 6 months with a retinal detachment. He was high myopic, and so whether the surgical, because they have fluid vitreous also, so we have to follow them up closely, because immediate post-operatively, he had good vision, so we can't ask them to come after a very long time. They need to come again. Especially if they already had a re-enclavation and second surgery, better to follow them up very, very closely. Because that child came for RD, with RD after 3 months. So we don't know when it happened. So they need to be closely followed up. Retinal detachment, touchwood, is not so very common as a complication. It is there, but we don't often see, isn't it? Do you? RD.
RD is rare.
Isn't it?
Very rare.
Yeah.
Yes. Only, madam, what is your experience in small pupil using hooks?
Actually, the other, I am very fond of most of these ring closed loop dilating rings and loops, but not in children, because all these cases have microphthalmia, and shallow anterior chamber, as already pointed out, is the most
very
difficult.
difficult.
Only iris hooks can be used, and then they keep on, because it may slip. And then it is very, very challenging in a child with a shallow anterior chamber, myotic pupil. Rubella used to be very common. I think for the past 3-4 years we are seeing more of CMV as an infectious cause, isn't it?
Yeah, true.
Do you also feel so? Because after the immunization became mandatory.
Videos have showed all of them are CMV positive.
All of them are CMV positive. Now, initially I used to always point out rubella as the cause, but rubella has come down now. And rubella used to create all these myotic pupil, small eye, calcific capsule, then anterior vitrectomy. Anterior capsulectomy has to be done with the vitrector. It's not possible to do a manual rexus. So all these problems put together in the rubella cataract, you have to follow them up for glaucoma. That is the most important. Second surgery is not very common. As she has already shown, inflammatory membrane occlusio pupillae can occur. Don't very commonly, because always we don't implant an IOL. And always in these children, very young children with small eyes, do a large capsulotomy so that the pupillary area is clear. And a good vitrectomy with so that not very common, but it can occur. Inflammation is very common.
I was thinking like whether you can give something to prevent this inflammation, because first post-op day it's okay, and first visit it is okay, but it's coming later.
I don't know. This is not a standard practice, but I give a very short
I used to give systemic steroids.
short of systemic steroids.
Systemic steroids have
Immediate post-op. Yeah, aggressive. That's what I do up to 9 years in older children. After 1 or 2 days of injection on the table, I do give one shot.
Usually in anesthesia you give no injection. Steroids are given, no?
No, Do
We
you?
usually give one.
Do you?
Our anesthetist give
Sorry, I didn't.
Do you
steroid.
routinely give steroid for children during anesthesia?
Not
I don't
exactly,
think
madam.
so.
Like we
Here we
selectively
give.
give for strabismus surgery because that is most emetogenic. So in those cases, we institute dual post-operative anesthesia preventing algorithm. Otherwise, not needed. But many patients may have some upper respiratory infection or hyperreactive.
No, I
In these
meant
cases, we may have
steroids.
to give.
Steroids.
Yeah, these
Dex,
patients. No, let me clear about it.
Routine steroids in during anesthesia.
Routine steroids are not indicated during the anesthesia, but what I was telling is that postoperative nausea vomiting prevention, this dexamethasone has a role, like a dual therapy with the dexamethasone and emisset ondansetron has a role. So
This is for the edema or
what?
dexamethasone?
Dexamethasone is for reducing nausea and it acts as the
For the
CTZ.
tract or for the eye?
For the CTZ.
Huh?
For we are giving it for the something called the chemotactic trigger zone, which stimulate this nausea. So when you are giving dexamethasone, that will prevent stimulation at the CTZ, chemotactic
Central.
trigger zone,
Central.
central action. And for emetogenic surgeries like strabismus surgery, we routinely give dexamethasone. Or if the patient has a hyperreactive airway, like an asthmatic kid or a recent upper respiratory infection, these cases we give dexamethasone. Otherwise, no routine role for steroids in anesthesia.
I think in our place they are giving because we usually ask them when we plan to give, no, then they say that we have given already. So we start only next day.
Yeah, I always on the
That's a
table.
good plan. Like some cases, you have to communicate with the
Yeah,
anesthesiologist.
they usually say that they have
Mostly,
given.
most of the people this dexamethasone has multiple beneficial effect intraoperatively and postoperatively. So many anesthesiologists has a practice of giving it routinely. Is there any contraindication from the ophthal side for this?
No
No,
contraindication.
actually it's good.
It is good. It is good because I do give on the table according to the
Used to tell me also give
Yes.
steroids on table.
yes. Newborn babies 4-6 weeks I give half cc on table. Then next day and we don't remove the IV line till next day when we see whether there is inflammation. You can see a very clear AC with pupil, round pupil, mid-dilated pupil or well briskly reacting. Then we switch to oral. Otherwise, if you still think there is something, then we give a second shot next day. Usually post-operative within
But it comes later also.
it can come. It can come. That is why frequent follow-up is important during the first 2 weeks.
Not the usual MLR, all those behave very well. But these microphthalmic eyes and with PHPV, it can come later.
Yes.
No, because some of the patients I know that they are looking after the baby really well because they are quite educated. Even I told them like that child was positive, I think cytomegalo. Then I told them like you look at, I just showed them how to look with the torchlight. And that next day they got that. When they saw that pupil was occluded, no, the parents were IT people. They brought the child immediately. IOP was normal in that child. Immediately as they saw the pupil was occluded, they brought the child. Actually, it was just first 2 days we give 1 hourly. After that 2 hourly and then 4 times we bring it down. But this child actually it was continuing as 2 hourly because I was expecting this. So they got the child immediately. I did a membranectomy, opened the pupil. I was quiet. IOP was not raised. But after that, child went home. Again, the same thing happened. Then Dr. Divya, a retina specialist, she did a pars plana membranectomy. Now the child is okay. So something is there, like which is inducing the inflammation.
Lot of things which occasionally, very occasionally, they come out of the way. But otherwise, because of the because of probably good vitrectomy and PPC and all that, over the years I have found that they do very well. than
Usually
previously.
rarely
Inflammation,
get such
inflammation
cases.
is not so very common
Usual pediatric, no.
with steroids. Yeah.
The video I showed with occlusion was not the baby I'm talking about. That baby, they were from Malappuram. They came after 3 or 4 weeks, and it was really bad. And it was a bad microcornea also. And one eye I couldn't save actually. I did all the membranectomy, retina people saw. And the other eye now is just like a pinpoint pupil. I'm afraid to touch it because there was so much of fibrosis. Whatever I do, no, again the fibrosis comes. So I said, don't do anything in the other eye. I sent them for a second opinion everywhere because I didn't want to touch on that eye. Child is seeing well. Maybe somewhere through the small pinhole they're seeing. But you can't touch that eye. This eye we couldn't say whatever we did.
So these microphthalmic eyes, are you scared of the nanophthalmos kind of uveitis?
Yeah, that can, but that I've
In the
never seen
child,
actually.
yeah.
Don't know.
Because nanophthalmos, according to our definition, is less than 20, and all these children, when we have to do, it is before definitely 16.5, 17, we don't know. But we have not specifically looked for nanophthalmos, but definitely they are difficult cases to do. Real microphthalmic eyes and micro, all of them mostly they have a small pupil also.
Yes.
And
that's about-
post-operative management is more difficult because to see the fundus, cupping, all these are very difficult. You put any number of atropine or whatever, and so then you have to put under, even under GA, seeing the disc is very difficult.
The
sometimes.
corneal, if you have a decent corneal diameter, then your surgeries will be okay. Corneal diameter small is the biggest. You can get away with the surgery, but this post-op problem is the biggest hassle. Hmm?
Means glasses instead of contact lens if the parents are not at all.
Glass.
That is the most often that is the case because we routinely give contact lens. The second time they come, they ask for a spectacle only, but it is still difficult because the other eye is seeing. So then making them wear contact spectacle and patching is very difficult. That's why even below 6 months we prefer to put an IOL.
Yeah. Otherwise, there's no point. And unilateral cataracts, now I put IOL very early. If
I
the
put
corneal diameter is more than 10.5,
Sometimes it is
almost 10.5, and the capsule is more or less rigid, little bit rigid, then I put the IOL and I'm putting 3-piece in the sulcus. So I'm thinking anything happens, remove it and replace it.
we do also the same, and we push it to 10.5 to make it 10 to 10.5. So it's very subjective because that gives better
Results are really good. Mm.
post-operative. Let's see, many children with an IOL management post-operative is better, definitely better than no IOL and spectacle. Vision also, long-term vision.
What a time, 1:30.
Thank you so much.
Okay,